Good morning, everyone. I think we have pretty much a quorum, so we'll go ahead and get started if that sounds okay to everybody. It's going to be very mellow, casual session the way gastroenterology usually is. And what we're going to be talking about today is guts and good health, pretty much the concept that you are what you eat, and particularly the role of the GI tract, maintaining it, nutrition, activity, screening in preventing gastrointestinal cancers, all GI cancers. And my name is Sharmila Anandasabapathy. I'm the medical director of endoscopy at Mount Sinai. My specialization is actually upper gastrointestinal cancers, Barrett's esophagus, esophageal cancer, acid reflux disease. With me today are some of my colleagues who I work very closely with, Dr. Michelle Kim, who is our Associate Director of Endoscopy and Director of Endoscopic Ultrasound. Michelle has an interest in pancreatic cancer and neuroendocrine tumors of the pancreas, but she'll also be talking a little bit about colon cancer today, since that's one of the ones that's most commonly on people's mind and certainly one of the most prevalent in the United States. And also with us, very importantly, is Laura Manning, who's our Director of Nutritional Services in the gastroenterology faculty practice. Laura is actually the person who is probably the most sought after, because everyone wants to know what to eat and how much of it, also what to drink and how much of it. And what not to eat, exactly. So we're going to start off talking basically about the primary GI cancers, what to do to prevent them, nutritional management, also diet and activity management. We're not going to speak for more than about 8 to 10 minutes, and then we're going to open up the floor for a very informal discussion. So I encourage you to think about what questions you have and feel free to ask us as a group, and whichever one of us feels the best equipped to answer that question, we'll go ahead and do that. So just a little bit from us, and then the rest will be all you. All right? Thank you very much.
So I think first we'll start off by discussing a little bit about colon cancer. Certainly it's probably one of the cancers that you've heard most about. It is one of the leading cancers in the United States. It's the second most common cause of cancer deaths in the United States, and so certainly it's a problem that many of us will face either directly or indirectly. And despite the fact that it's an incredibly treatable disease, incredibly preventable disease, we're having very large numbers, 150,000 patients a year who will be diagnosed with this disease, and then about 50,000 who will die. So from our point of view, as people who care for patients with gastrointestinal diseases, who care about optimizing gastrointestinal health, this is unacceptable. It's too high, and there are definitely ways that we can use, tools that we can use to try to prevent this. So the first thing, is just a little bit of background information. How do we get colon cancer? What can we do to prevent it? So the first thing is certainly it's going to be the vast majority of situations what we call sporadic. In about 3/4 of situations, it won't have any sort of predilection with a genetic history or with other identifiable risk factors. So it'll just be any one of us sort of average people sitting around in a room. In about 20%, there will be a familial history that is associated with it. And so there will be some risk factor that you can identify somewhere in the family for someone with colon cancer. And so knowing that, why do we screen for colon cancer, and what can we do to prevent it? Well, first of all, the thing is that makes it so treatable is the fact that you can detect them before they become cancerous. You can detect growths. So if you do have a colonoscopy, if you had that colonoscopy, you know that you can detect something called polyps, which are precancerous growths. And what we're doing is detecting them and at the same time at colonoscopy removing them. So that it doesn't sort of develop and continue to develop in your body over years into what ultimately becomes a colon cancer. So the fact that we can detect these things early, detect them, and remove them really is what accounts for our success in being able to prevent colon cancer. There are lots of different kinds of polyps. Probably the ones that you're going to hear about most are something called adenomas or adenomatous polyps. These are the ones that typically can grow into the colon cancers, and so these are the ones that we are trying to detect and trying to remove. They're going to be a little bit more common in men. This is a group of women. However, I would sort of bet on saying that probably most of you have a man in your life in whatever way, father, brothers, spouses, uncles, and nephews. And so certainly I think as women, and women who often care for many sides, including the physical health of people around us, I think certainly it's something that's important. It's important that sometimes these can be in different locations in the colon. Those in the right side can tend to be the right side of your colon, which is the ascending colon on this side, can tend to sometimes have some features that may give you a little bit more risk for colon cancer. And then there are certain features also within polyps, something called villous adenomas or tubulovillous adenomas that can be even more advanced than your usual adenomatous polyps. And so those kinds of features are also things that we're looking for on our exam, and then certainly the pathologist is looking for once we remove it and they cut up the specimen into slides. There are some other polyps called sessile serrated polyps. You may hear about this from your doctor. Again, these are the ones on the right side that might be sort of a little bit more tricky to manage. They definitely need to be removed. These can also predispose you towards colon cancer. And so these are a type of adenomas that are important to know about. In terms of risk factors for colon cancer, you have sort of your environmental risk factors, your genetic risk factors. The environmental ones are going to be the things like smoking. Certainly, smokers are going to be at risk for colon cancer. Duration of smoking certainly is associated, so if you do stop, that does help you in terms of lowering your risk for colon cancer. Obesity, you're going to hear a little bit more about, but obesity is certainly associated with colorectal cancer, so we can talk a little bit more about what makes a healthy person and what's a healthy weight to aim for. Diet, a low-fiber, high-fat diet. This sort of also correlates a little bit with this obesity issue that we were talking about. And then you have a number of genetic factors and a number of sort of demographic factors that are not really under our control that can also be associated with colon cancer. Definitely age. As you get older, you're at higher risk for colon cancer. And so it's really important you get not just that screening exam, but also the surveillance exams after that to make sure that your colon stays healthy and polyp-free, cancer-free. African Americans can have an increased risk. And so actually in recent years, there's been a push to start screening, not just at age 50, which is sort of the age that you hear most about, but for African Americans, age 45. And so this is something important. Certainly any family history, personal history of colon cancer, polyps, you're at risk for developing other polyps and other cancers, so that's important. Inflammatory bowel disease, anybody who has Crohn's disease, ulcerative colitis, people with these diseases, especially as they have a longer duration of disease, those people need to be screened as well. And then finally, there's a lot of genetic syndromes that often can run in families. FAP, familial adenomatous polyposis, HNPCC or Lynch syndrome. These are just a few of the syndromes that can be associated with an increased risk of colon cancer. And so folks who have these cancers often are screened earlier and then surveyed more frequently. In terms of the clinical features, I think a lot of you know that certainly there are some gastrointestinal symptoms that can be associated with colorectal cancer. The scary thing is that also not having any symptoms can be associated with it. And so this is really why, even if you feel completely fine, it's still important to get that screening exam. A lot of people will say, I feel fine, everything must be okay, and you just can't be sure. Certainly rectal bleeding, and I'll say here that people often will come in and say that, oh, it's my hemorrhoids, I know it's my hemorrhoids, and it may well be hemorrhoids, and that's certainly a common reason for rectal bleeding. But unfortunately, you can never be sure, and certainly rectal bleeding can be a cardinal sign of colorectal cancer. Anemia, particularly iron deficiency anemia. This is unfortunately something that is also very common, can be mistaken in young women also for menses and for having periods. And unfortunately, you just need to be clear sometimes that anemia, especially iron deficiency anemias, are not being caused by something different. Abdominal discomfort, there's no particular place in the abdomen where this can happen, but really anywhere. Change in bowel habits or unexplained weight loss. I think unexplained weight loss is always a sort of a cardinal sign, an alarm symptom whenever we see patients who have that. There's a lot of different screening tools you can use. I think, again, the most common one you're going to hear about is colonoscopy. But there are other screening tools. There are non-invasive tests that you can use in terms of looking at the stool and looking for blood. There are also sort of what we call flexible sigmoidoscopies, which are sort of an exam of a third of the colon, the bottom third of the colon. There's something called a virtual colonoscopy, and it is virtual in the sense that it's not a tube going up the rectum, and in that sense it is virtual. On the other hand, you still do have to take a preparation for that virtual exam. So to a lot of us gastroenterologists, we feel as long as you're doing the preparation, you might as well sort of go and have your colonoscopy. Again, the benefit here for the colonoscopy is going to be not only detection, but also the fact that you can remove and you can treat. Let's see. There are just a few things I wanted to say about sort of making sure that you have a quality exam and also making sure that you understand some of the choices you have when you have a colonoscopy. So the first thing is that in quality, there's a lot of things that you can do to actually improve the quality of your exam. One of those is definitely making sure that you have a good preparation. This is by far one of the biggest things that we hear about in terms of, the horribleness of it and sort of how inconvenient it is, the fact that you're starving after an exam. But unfortunately, the better the prep is, the better we can see. And it's very simple. If there's stool in your colon, we often might have to have you repeat it. We can't see around corners, detect small polyps, which is all of what we're trying to do. And so, if you're able to really get a good prep, that will really help us to have a quality exam. There's a lot of polyps that are not obvious. They can be behind folds or on the corners. They can be very flat. They can be really hard to see. So again, getting that prep and having it really good can make for a better exam. Withdrawal times is also important. This is something that you can talk about with your gastroenterologist. It sort of makes sense that the slower you look at the colon as you come out, the more you will see. And so there have been some studies that say that when you do have your colonoscopy, you should have a withdrawal time of at least 6 minutes to ensure that your exam has been a good quality exam. In other words, that people are not just sort of whipping out the scope when they come out. Some of the choices you have in your colonoscopy and in the preparation for it. So the first thing is that a lot of different doctors will have different thoughts about the diet that you should maintain, both sort of, I would say, in the week preceding the colonoscopy and also in the days before. Some people allow in our practice, we allow mostly clear liquids, although a very light breakfast the day before. Some people allow a little bit more. You'll have some choices about preparation. I would urge you all to make sure that you have what we call a split dose prep. This has been something in recent years that shows that if you have half the prep the day before the colonoscopy and half the prep the day of the colonoscopy, and you split the dose like that, then your prep is going to be better. So again, in having that good prep, we can always detect better and detect more subtle findings. In terms of the sedation, there's a lot of different ways that people are doing sedation in the city and certainly outside of the city. Are you going to have an anesthesiologist or not? And in our institution, a lot of our exams are done with anesthesiologists. We think that there's benefit to having somebody exclusively care for your airway and monitoring your vital signs. The other thing is that these medications that the anesthesiologists give are sort of very quick acting and quick to come off, and so the time that you're actually under anesthesia is much lower, and the turnaround is much faster. So we feel that that's a very positive aspect, and our patients often report being very comfortable. Who will do your colonoscopy? Again, a lot of choices out there. There are a lot of women and even men who prefer to have female providers. And so this is definitely something you can look for, definitely something you can ask for. And certainly at Mount Sinai, we have, I think, over half of our GI faculty are women. And so certainly there are many providers. Where will you do it? There's a lot of different places you can have it done. You can have it done in a doctor's office. You can have it done at ambulatory endoscopy centers. You can have it done in a hospital. Most of ours tend to be done in the hospital. We seem to like that in terms of the safety issues, in terms of some of the other things that arise, but there are definitely choices that you have. And then finally, when will you do it? Certainly evening hours, Saturdays. Some of these are available in different institutions. Again, we have evening and Saturday hours, and so this is something that can sometimes be more convenient for those folks who have commitments during the day. And then finally, just wanted to mention a word about surveillance. I mean, once you've had that screening exam, it's really important. Again, your risk is going up as you get older, so you need to make sure that you stay under surveillance. So like your pap smears, like your mammograms, you just need to sort of keep up with this to make sure that you optimize the health of your colon. And so that will depend on what your risk factors are. So for the average person who has no polyps, their follow-up colonoscopy will be at 10 years. A lot of doctors don't feel quite comfortable with waiting the full 10 years. They think that, if there's a small chance that something was missed, maybe they'll have you come back a little earlier, like at 7 years. But then depending on your personal risk, depending on any symptoms that you developing having other risk factors, you may be asked to come every 3 or every 5 years. And so these are all different things that will be sort of discussed with you as you have these procedures. So I think with that, that's sort of my brief spiel on colon cancer. We're going to move it down, or move it up rather, at the GI tract, and move it to Sharmila.
So I think, we need to remember the GI tract is sort of plumbing. So if we think geographically about going from north to south in terms of cancers, I think Michelle's covered the south. Moving upwards a little bit from the top down, other relevant cancers to think about in terms of screening and prevention are esophageal cancer, which is probably the most rapidly rising cancer in the United States today, gastric cancer, so stomach. Then think of surrounding organs, of course, liver, pancreas, moving downwards, small intestine, those 20 feet of it. Not actually a common location for cancers, but one to be aware of, especially if you have a family history or certain syndromes, which you'd probably know about. And then, of course, the most common in the United States today is colon. I think the one kind of overarching concept that everyone should really think about is that if you want to prevent gastrointestinal cancers, maintain a healthy body weight and nutrition. We'll talk about that in a little bit. That's critical. And stay away from cigarette smoke, either smoking on your own or even secondhand smoke from other people who are near you. These obesity and smoking seem to be associated with not just GI cancers, but most cancers in particular. So that's something to think about sort of across the board. And Laura will talk a little bit more about diet and lifestyle, alcohol and other factors. These can vary depending on organ and the particular type of cancer, also family history as well. So we'll touch on that in a little bit. Esophageal cancer, I mentioned, this is something which is on everyone's radar because it is rapidly rising. It's actually undergone a 400x increase over the last 3 to 4 decades. So this has had the highest rate of rise of any cancer in the U.S. It still has not even come close to colon cancer in terms of the numbers of people affected, but the rate of increase has gotten everyone a little bit scared. Now, why are we seeing so much esophageal cancer in the United States? Well, historically, actually, most of the esophageal cancers were arising in lower resource parts of the world because it was a different type of cancer which arose usually from nutritional deficiencies, the way foods were prepared. This is very common in East Africa and northern China, Iran, or injury to the esophagus. In Iran, actually, the temperature of the tea that is being consumed by most of the population is what's associated with the cancer. So they're literally burning the lining, and that's causing inflammation and cancers in those areas. But in the United States, the primary reason for the rate of increase in esophageal cancer is actually obesity. And why? Because we eat more, we gain weight. The most common location for weight gain is actually central, is in the abdomen. This causes pressure on the diaphragm, increased levels of acid reflux disease, and it's heartburn and acid reflux that are associated with the development of esophageal adenocarcinoma, which is the one that we are concerned about in the U.S. Now, historically, people always told women not to worry about esophageal cancer, that this was a cancer that mostly men get. And actually, if you think of the typical esophageal cancer patient, I think of sort of Homer Simpson, lying on the couch, pot belly, and that is actually sort of the standard profile. However, the rate of rise of esophageal cancer has risen dramatically in women, and it's about 29% of esophageal cancers actually occur in women. And historically, this was a cancer of Caucasian men, but this is not true anymore. We're seeing it in minorities and other populations as well. So this is one to be aware of. When do you talk to your physician about it? Well, if you have frequent or what we call long-standing symptoms of heartburn, then this should be something that you should bring up at the very least with your primary care physician. What do I mean by frequent? Well, certainly if it's been going on for months, I would bring it up. If it's going on for years, you probably need to be evaluated for endoscopic screening by a gastroenterologist. And by frequent, we mean more than daily. So if you have heartburn 1 or 2 times per week, this may actually be considered normal. If we go to a party, we overeat. Sometimes people get intermittent heartburn. If you eat or you lean over or do sit-ups, you may get intermittent heartburn. That's not actually abnormal. It's when it's every day, when it's bothering you, and certainly if you're having nighttime symptoms or getting out of bed with heartburn, that's something to think about. The other thing to think about is not everyone may present with heartburn. Some people present with regurgitation, the feeling of food coming up into the throat, sour taste in the back of the mouth, which can be a sign of acid coming up from the stomach. It's actually a very unpleasant situation. It's something that bothers patients the most. Other symptoms of reflux disease can include cough, believe it or not. Sometimes asthma can be associated with acid reflux disease from microaspiration, from acid coming up from the stomach. Hoarseness. People often tell me that they started to notice a change in their voice, and this can be a sign of reflux. It's actually very difficult to treat this type of reflux, and oftentimes patients come to us by way of otolaryngologists or ENT doctors because they're the ones who see this. And the other sensation which is important to think about is a sticking sensation in the throat. Sometimes sticking sensation can be due to movement disorders, sometimes it can be due to anxiety even, but sometimes this can be a symptom of actually acid coming up into the early or the beginning part of the esophagus, the food pipe. So these are all things to think about. Esophageal cancer is something which we screen for by upper endoscopy. We're specifically looking for a precancerous condition known as Barrett's esophagus. Again, the typical patient with Barrett's esophagus is Homer Simpson, but you never know, and I'm always surprised at who I might find Barrett's in. And again, Barrett's is most common in patients who have long-standing acid reflux disease. It actually occurs in about 1.5 to 2% of the American population, so 1 in 50 people will have Barrett's. And the most important thing to think about with Barrett's, and I believe with all GI cancers, is that if you opt to go for endoscopic screening, we're not looking for cancer. We're trying to prevent cancer. We're looking for the precancerous lesions or precancerous changes that will lead to cancer. So there is no reason to be afraid of going for an endoscopy if we find the precancerous changes early, or if we even find cancer when it's small, less than a centimeter, can find the lining, what I tell patients, in the paint and not in the sheetrock. We can remove it through our scopes. We can treat it actually on the spot very often, and this will most likely be something that will never affect your life expectancy. So anything that is found early is basically curable, and this is really the argument for endoscopic screening for most of these. Gastric cancer, actually, something to just be aware of, but rates are actually declining in the United States. Gastric cancer is typically due to a bacterial infection known as Helicobacter pylori. This is more common in East Asia and South America, where rates of this infection are high. In general, as lifestyle gets better, as societies tend to advance socioeconomically, the incidence of this cancer tends to drop. There are other types of gastric cancer as well, neuroendocrine tumors, lymphomas, but much, much less common. Pancreatic cancer, talk about it very briefly. This should be on your radar if you have a family medical history of certain syndromes that are associated with pancreatic cancer. The other thing to think about in terms of mentioning screening would be there's an association with the breast cancer gene, BRCA, which is something to think about as well. And I remember watching Angelina Jolie go on the news to talk about her mastectomy, and I remember looking at my husband and I said, did she get screened for pancreatic cancer? So it's not associated with every type of mutation, but it's something to think about and something perhaps to ask your physician about if you may warrant screening for that. There's a number of tests which may be suitable for that or ways of doing that, but typically if you don't have a family history, this would not be something that you would be screened for. The other thing, again, pancreas also, cigarette smoking and alcohol. stay away from as well. Liver cancer is not very common in the absence of existing liver disease or hepatitis, viral hepatitis, hepatitis B, hepatitis C, alcoholic liver disease. There's benign liver tumors as well, but again, not as common as some of the other cancers we're hearing about. And again, small intestinal cancers, 20 feet of the small intestine, much, much less common. Really the biggest ones to worry about are colon. Just by a mile. That's the most common to think about and eminently preventable. Esophagus, if you have certain symptoms or risk factors. And gastric, if you have a history of ulcer disease or family medical history of certain types of syndromes which may predispose you to gastric cancer. So family history is one important thing to think about with the other types of tumors. Okay. I think the next person who I think will be filling in a little bit on what to do to prevent these is Laura Manning, who is our Director of Nutritional Services for GI.
All right. Good morning. Thank you so much for joining us today. And I see some women from the Armed Forces, and I welcome you, and thank you for coming. It's exciting. So I want to talk about 7 points of our nutrition and health and lifestyle that we can actually start to do in order to potentially prevent any of these cancers. And I'm going to target specifically the GI cancers, which is why we're here today. So the first thing I want to talk about, and it's been mentioned already, is obesity and maintaining a healthy weight, getting to a healthy weight and maintaining it. So we have something that we like to look at. It's called a BMI, body mass index. So everybody should fall within a number when we do a little math calculation that's between 18 and 25. So we can actually calculate that in our heads. So a woman, typically at 5 feet, should be about 100 pounds. And then you do about 5 pounds for every inch above that. So if you fall about 10 pounds up or down from that, that means that you're in a healthy weight. And then, again, like I say, we do a little calculation. And if you go above 25 on your BMI scale, then that means that you need to really work to get back down into the 18 to 25 zone. And it's really important to do that. It's really probably the number one thing that we can really do for ourselves. So we have our bodies, and actually the way that the fat is distributed is really important too. So we talk about apple versus a pear. And if you have an apple shape, that's more abdominal, centralized fat. And that really is something that we need to try to work on versus a woman that has more of a pear shape where the fat is a little bit more on the hips and the tush. So keeping our weight at a proper BMI is incredibly important. And actually a really important piece of advice is just to not get heavy in the first place, because then we don't have to do all that work to get back down to a healthy place. So how do we do that? We have to increase our activity level. That's really important. So we have recommendations about how much exercise we should actually be doing in a week. And the recommendations are to be doing approximately an hour a day for 5 days out of the week. Now, that doesn't mean that we should be training for marathons and we should be doing some really hardcore weightlifting or anything like that, but it could be very simple changes in our lives that can actually be accumulated for 1 hour. It could be 10 minutes here, 10 minutes there. So that means that what we can simply do is we can walk to work. We can get off the bus one stop before we actually have to get to our destination. And if we're at work, we can take the stairs instead of the elevator. And these tiny little changes can actually make a huge difference over time. And it can actually cut our calorie intake by 100, and that's how we maintain our weight to stay right where we need it to be. So physical activity is really important. If we can sort of start with maybe 2 days a week, where we can give ourselves an hour a day, and then work ourselves up to 5 days a week, we're doing a tremendous amount of benefit to our bodies. And we actually have an advantage living in Manhattan, if you're all from here. We are a walking city. So the more that we walk, we actually can do more for ourselves as opposed to like the suburbs where you have to get into a car and you have to drive everywhere. So we have an automatic advantage to ourselves as it is. All right, so we want to make sure that we have a really good weight, and we want to maintain it. We want to get that physical activity in there and up. And actually, the more vigorous we do make it, it is better for us for a whole host of reasons, cardiovascular-wise, but we want to get active and stay active. All right, so what do we eat? All right, we have to make sure that we really, really pay attention to this and get our fiber up. What's great about fiber which is in your fruits, vegetables, and whole grains, is that it actually makes us feel fuller longer. And the longer that we have like a satiated feeling, the less we're going to eat over time. And that keeps our weight down. So the goal is the number 5. All right, we want 3 vegetables and we want 2 fruits. And that's actually supposed to be the minimum a day. I don't know about you guys, but think about it. Are we all getting 5 in a day? It's a lot, but it's actually 5 to 9. We're supposed to get 5 to 9 servings of fruit and vegetables a day. So a serving of fruit is a piece of fruit or a cup of cut up melon. A vegetable is 1 cup raw or half a cup cooked. All right, so if you have a cup of vegetables, that's actually, sauteed broccoli, whatever. It's actually going to be 2 servings right there. So think about it. Remember the number 5. That's really important. Okay? Throw in a piece of fruit in your breakfast and your lunch. Have a vegetable at your lunch and your dinner. Then you're good to go. Okay? Juices, do they count? They could. But it's really about actually eating the fruit versus the juice. And we can talk about juicing because that's a hot topic. Okay. Whole grains. We don't want anything white. I want you to think about the colors that you eat. Anything that's processed is not really going to have that high fiber in there. So white breads and croissants and stuff like that, those are going to actually make us feel hungry pretty quick. So we have the whole grains in our breads and so forth, our cereals. We're actually going to feel fuller, longer, and get a lot more benefit. And actually it helps to increase our GI tracts, to help clear us out to the best that we can. And that's really important too. So we want to get, whole wheat bread, whole wheat pasta. They actually make some really good tasting ones now. It used to be horrible. Quinoa. We want high fiber cereals, brown rice. So we want to get color, okay? We want to stay away from anything that's white, anything from a box, anything that is processed. Processed foods are not really helpful for us. All right, so let's talk about the next thing is red meat and processed meats. Those are really one of the biggest things that we can look at in terms of science, in terms of what foods we eat that actually can contribute to GI cancers. Red meat, what is it about red meat? It's actually when we eat red meats and we have that charring on it. You put it on a grill, and when the fat drips off the meat and it hits the flame, or whatever heat source there is, it splashes back up and it makes that charring. That's actually something called heterocyclic amines. Those are cancer causing. All right, so we have to really take a look at how we prepare our foods too. Never mind the saturated fat content contributing to obesity and cardiovascular issues too, but for GI cancers, it's actually that charring. Now we have red meat, and then we also have processed meats, and those are cold cuts, hot dogs, salami, all of those meats that actually have a really long shelf life. Well, that's because they have something called nitrites in them. So read your packages. That is a preservative. It also helps to be antimicrobial, and it also extends the shelf life in your refrigerator. So what do you want to do about that? You want to get things that don't have nitrites in them. Nitrites are known to cause cancer. I'm not saying to never eat these things again, but really you want to cut down on the deli sandwiches. Go for some grilled chicken instead, or go to a deli that has an actual turkey, then you could slice it right off the bird instead of these more, name brands. I don't want to name them, but they really really should go for actual foods, not things that are manufactured and packaged. So red meat's a big deal. We should be having at the most 3 servings a week. I personally would like for everyone to have less. But if you can really cut it back to 3 servings a week, and maybe remember that the size of a portion of protein is about the palm of your hand, okay? 3 times a week. Okay. So in addition to red meat, keeping a healthy weight, getting our fiber up, I want to talk about alcohol. Alcohol, I'm not telling you never to have it again, but we need to really make sure that we cut back on it. If you don't drink, don't start, okay? That's really the big ticket here. But if you do, for women, the recommendation is that we have 1 drink a night. All right, so that means, it's a glass of wine, a beer, or a cocktail. And banking it all up on the weekends does not count. So if you consistently have it, if you have 1 a night, it's okay. But if you don't have it, don't start. Okay, so we really want to make sure that the alcohol is kept at bay to the best of our abilities. And there's a lot of talk about supplements. Do we take a lot of vitamins? The more trips to the health food store asking about, what to take and herbals and stuff like that. Is it really important to do that, and is actually benefiting us? There's a lot of people that are actually taking too much of a good thing. And I want to stress to you that the best thing that you can do for yourself is to actually eat the food instead of take the pill. Unless you have some sort of an issue where you need to, quote unquote, fill in the gaps if you're not getting a healthy diet in. There are in colon cancer and any kind of GI cancers, they are seeing that if we have calcium at the right amounts and vitamin D, that it actually can be protective for us. So how much do we actually need? For women that are 50 and under, we need about 1,000 milligrams of calcium a day. And that's about 3 servings of low-fat or fat-free dairy. And that's pretty easy to get, even if you are not taking dairy products. If you're lactose intolerant, you get gas and bloating from it. There's also rice milk, almond milk, soy milk. Those all are fortified with calcium and D. And it'll be just like you're having a cup of milk. You're not going to be missing anything. In addition to dairy, you can eat things that have bones in them. If you eat bones, you'll actually get the best source of calcium. And that's in having things like canned fish, like sardines or salmon, where you actually can see the bones there. That's fantastic for you. In addition to getting some omega-3s, which is really anti-inflammatory. It's wonderful. And also there's some green leafies, and almonds are pretty good too. Very, very high in calcium. So it's good for you to include those things. Vitamin D is also important. We have to look at our geography. There are certain parts of the world and in this country that if you are farther away from the equator, you have less exposure to the right amount of sun that can help to manufacture vitamin D, because we make it through our skin. So if we don't get enough sun, we're inside most of the day. It's cold out. Who wants to go outside? You need about 10 minutes a day on your hands, on your face. We're wearing a lot of sunscreen these days. So you can take a supplement as well. And that's about between 400 and 600, what they call international units a day. And you can probably get that enough from either taking a supplement or from the fortified dairy products that you consume. So if you're over 50, the increase in calcium becomes 1,200 milligrams. That's like having one more serving a day. And the same is for the vitamin D. It's 400 to 600 international units. Just a little tip. I know that Greek yogurt is super popular right now, but did you know that regular yogurt actually has more calcium than Greek yogurt? Even though you would think that it's thick and rich and you would think that it would have more calcium, it actually has less. So if you're interested in using yogurt as one of your ways of getting your calcium up, go for actually regular yogurt, but not too much sugar. Okay? So in addition to all those important points about how we can protect ourselves from how we eat in our lifestyle, is also to make sure that you get screening, which they have very, very specifically told us all the different risk factors and when we should start. So that's what I have to say. Anybody have any questions?
We'll open it up to the room. And I know they're bringing some chairs in, but there's a couple seats up front as well. Yep. Right there, yeah. Yep.
I have a two-part question about adenocarcinoma and Barrett syndrome. One is that a familial cancer? And also, is there any risk in taking drugs like Nexium?
So esophageal adenocarcinoma is not considered a familial cancer. It does cluster in families. We're seeing fathers and sons who have it, or fathers and daughters who have it. But we don't think it's genetic. It may be a combination of some type of environmental issue, possibly they're eating the same diet, or some component that's genetic as well. But certainly if your father had esophageal cancer, you may want to bring it up with your doctor, but you're not at higher risk than the general population. In terms of Nexium and those medications, I have one very clear thing that I tell my patients about this. The only reason to be on those medications are if you have symptoms, and those medications are there to treat your symptoms. They're not preventing cancer, and they're not treating the Barrett's. So basically, if you don't need to be on those medications, even if you do have Barrett's, even if you do have precancerous Barrett's, you don't need to be on the medication unless you're having heartburn, regurgitation, sticking sensation, cough, or something that warrants treatment. It's not actually associated with an increased risk of esophageal cancer. It is associated with an increased risk of gastric polyps, which are benign. We don't know what the long-term consequences of those polyps are. The other thing to take into consideration is that long-term use of those medications can be associated with a slightly increased risk of osteoporosis and hip fractures because of calcium absorption. So again, typically I don't like to keep my patients on them for too long. And the only reason to take them are for symptoms, not for cancer prevention. So we'll start right over here, the striped shirt.
I noticed that none of you talked about the role that stress may play in gastrointestinal diseases. Maybe that's not part of the program, but for me personally, just an example, I think for a lot of women, especially doctors, oh, you're too stressed, and nobody can seem to always to figure out what the interplay is between diet and stress, because it's a little easier in some ways to control diet than it is stress, especially in New York. We all live in a pretty stressful environment. So I was just wondering if any of you could talk about how you figure out that part of the puzzle and how you cope with it.
Well, I can start by saying that there's a very strong brain-gut connection. From what I understand, and they can compliment me on, is that what you eat, and in a very stressful environment, it could cause reflux. I mean, you could regurgitate it because you're running and you're trying to shove a sandwich down, and you can't digest it properly, or eating very high fat meals. So there is a way that stress does cause problems, and it also can cause major constipation, diarrhea. So it can be also how your bowel function is as well. I'm sure that there is a component of it.
With that, certainly I think that stress plays a major role sort of in how you feel, and a lot of those symptoms can manifest in the gastrointestinal tract, whether it's abdominal discomfort, gas, bloating, changes in your bowel habits. In terms of stress being a risk factor for gastrointestinal cancers, that has not been demonstrated. So from that perspective, we should be all right. But I do think that in terms of managing stress, in terms of reducing stress, it's important just in terms of how you feel day to day.
I'm going to go all the way to the back there. Yes. Right there, yep.
I have a question about inflammation, because specifically as a group or as it relates to IBS, but from what I understand, inflammation of any kind in your body is terrible and can lead to cancer or precancerous things. And so is there anything that you can talk about in terms of relating to IBS to soothe inflammation for your intestinal tract?
So I think here we need to sort of make a distinction between, you're right in that inflammation does sort of promote sort of the carcinogenesis process or the development of cancer. Generally speaking, however, it's more sort of the inflammation that can be visualized on a colonoscopy. So generally speaking, our patients who are at risk for colon cancer who have inflammation are the ones who have inflammatory bowel disease, not irritable bowel syndrome. So it's our patients with ulcerative colitis, with Crohn's disease, who we need to keep under surveillance. Our patients with irritable bowel syndrome need to be under surveillance for their symptoms, but not for the development of gastrointestinal cancer. Okay.
Well, for the backup, 1, then 2, then 3. Okay.
So while I recognize that it's totally anecdotal, in the last 6 months, 2 people in my life have been diagnosed with stage 3 and 4 colon cancer, having had colonoscopies that were negative in the 12 months prior. And in talking to my own, and these are people who live here in the metropolitan area, they're not, in third world countries. And in talking to my own GI, he said, well, the problem is with the proliferation of people going for screenings. There's a lot of people who are doing them who aren't as experienced. He talked about, they need to look on the way back when they do the colonoscopy. And my question to you is, as a patient, you can't say to your GI, are you sure? Or did you look? But what can you do to advocate for yourself to make sure that you're actually going to someone who's thorough? Because in both cases, it was missed.
So there is, this is kind of the, this is a very kind of a hot topic now in gastroenterology and in endoscopy in particular. There is a very high rate of missed cancers that have been reported in the literature, and people suspect that it may be over 15%. There's also a high rate of incomplete colonoscopies, believe it or not, in community-based settings. The likelihood of completing the examination is probably on the order of between 80 to 85%. So, there's a significant percentage of physicians who are not completing a full colonoscopy. There are also, just to provide the other side of the coin, lesions that are very hard to detect on standard endoscopy, which may account for some of those cancers that develop between screening and when the cancer develops. And these are flat lesions, what Dr. Kim referred to as serrated adenomas, that may be hard to see on endoscopic screening. This is a very new topic in GI, and we're trying to get around the best ways for identifying these. And it may be having non-standardized examinations with specialized scopes. So what does this mean, and what do you ask your physician? Well, there are standard metrics for evaluating endoscopists' competencies and success. So what are things to look for? Volume. Is the procedure unit, and is the doctor performing a lot of procedures? If they're performing 5 a week, I would get out of there pretty quickly. On busy days, I can tell you most of us perform more than 8 cases a day, so you want to ask what the volume for the endoscopist is. You may want to find out about complication rates, perforation rates, examination completion rates. How often are they getting to the colon, and are these published or available? Can you get these from the practice? There's also something which is being looked at right now, which is called an adenoma detection rate, where basically if they are not finding polyps in less than about 15% of the patients who are being screened there, something is wrong. And we don't know what that is. Maybe the scopes are old. Maybe the doctor's vision is old. But something is probably wrong. That might be a flag because they're not picking up enough polyps. The other thing which is very important is withdrawal time. And I think Michelle Kim had mentioned this before. The speed at which you come out of the colon is critically important. If you're coming out in faster than 6 minutes, 4 minutes, 3 minutes, you're missing things probably. And this has been associated with. So a lot of groups and practices are starting to publish this, and you can ask. I wouldn't be afraid to ask. Yeah, but a lot of the GI practices, ambulatory endo centers, and groups are actually publishing their quality rates. And the 2 most commonly published are those 2 that I mentioned: the withdrawal time and the polyp detection rate.
I think the other thing also just to note is that certainly, we've just said that colonoscopy is a terrific test, but they can miss lesions, and particularly those that are smaller, flatter, and tend to be in certain locations of the colon. Certainly, if there is a suspicion, however, if there's persistent anemia, if there's persistent weight loss, if there's a family history, if there's anything that really sort of makes the doctors or makes the family's antennae feel like there's something else going on that we're not catching, it's not unreasonable to have a colonoscopy repeated, in a short time frame. I wouldn't generally recommend this as a sort of standard practice, but if there's a clinical feature about the way somebody's feeling, an unexplained rectal bleeding, unexplained abdominal pain, that's not unreasonable. I know that we have definitely seen, where we have done colonoscopies on patients who have just had one within the last 6 to 12 months, and we've detected cancers just the way that you described. So it does happen, and I think that in that situation, it's worth either a relook with the same person or perhaps considering a second opinion.
My many hands. Right over here. Yeah.
Okay. I have about 4 questions. One, do the polyps grow back, or once they're removed, that's it? Be another polyp.
Right. Generally speaking, depending on what kind of polyp it is and assuming that it is endoscopically resectable, it will be able to be completely removed. And when we go back and do another colonoscopy, let's say a few years later, we're looking for not the polyps in that particular location, but in polyps in other areas of the colon. They generally will recur in different places.
So it's not uncommon to have to go back 2 years after the polyp was removed because other polyps might be
Correct.
suspected.
Correct.
Okay. Now, I've had abdominal obstructions. I've had 3, and I had 2 major surgeries. I almost died in people. Anyway, but the first time I had a colonoscopy about 6 months prior, and then I had the obstruction. Does one situation have anything to do with the other? Having a colonoscopy could tell you whether you may be having an obstruction or has nothing to do with it.
No, I mean, I would say the only thing is that obviously if there is a large polyp or if there's a cancer, then that can lead to an obstruction, but there's nothing independently about a colonoscopy that should lead to obstruction. The only other thing I will say is that if you've had a history of multiple abdominal surgeries, that in itself can make colonoscopy more challenging for the endoscopist. It can also make it a little bit more uncomfortable for you.
Because I have many, many adhesions.
Correct,
And
that's
doctor
right.
says I have tons of adhesions. Now, the prep for the colonoscopy, do you prefer one type more than other, like there's go lightly and there's all these other?
I think all of us believe, I think that the prep that we prefer is the prep you're going to take. So whatever the prep is that you can take and you can finish is the one that we want you to take.
What is the prep the day before? And
It's called a
the same day? I thought you finished the same day.
So very early in the morning, depending on the timing of your procedure, it should be the time that you should have a second dose. So it's called a split dose prep, and you can speak to your physician about more details about that.
And the last question is, if you have difficulty swallowing, and I've had endoscopy, and have had this ring, what's it called,
Schatzki's ring, yeah.
Am I more prone to getting cancer?
No, you're not more prone to getting cancer. You may be more prone to getting Barrett's because you probably have reflux, but not cancer. The other thing I just want to mention very quickly, that prep is very important because if the prep is not good, we do miss polyps. So your interval for your next colonoscopy may be shorter, or the doctor may ask you to come back, actually.
Right. And that is a fair question, actually, to ask your endoscopist is, how was my prep? Was it good? If it wasn't good, do I need to come back a little bit sooner for my next colonoscopy? That's a very fair question.
In the red?
Quick question. You talked about rectal bleeding. I was once told that if it's red blood, you don't have to worry that if the fluids or the blood is going to be black. Is that true or not true?
That's not quite true. So I would say that any rectal bleeding really needs to be investigated, whether it's red, black, or maroon, or whatever color it is. The one thing I will say is that I think if it just appears on the toilet paper every once in a while without ever appearing in the bowl, that is a little bit more likely to be something like a fissure or a hemorrhoid. But if that, in any situation, if the blood is in the bowl, that needs to be evaluated.
Right over here.
Regarding a person who has these multiple situations, and the question is which type of a doctor to go to. Person has osteopenia, allergies, GERD, and is required to take Photonics in the morning, Zantac in the evening, loses the voice, okay, and has gone to like a pulmonologist, allergist, and so forth, and then finds out that the vocal cords have been affected by acid reflux and has lost the voice for 6 months, okay? So this person keeps on coughing at different times. How does the person know what type of medication to go to and which doctor to go to?
This is something that's often managed by multiple doctors together, most commonly by ENT and GI. Commonly. Now, if you're aspirating into the lungs, pulmonary may be involved as well, but the management, which is really the reflux and the vocal cords, would be ENT and GI. What you may, or your friend or whoever this person would be required to do is they may need to get formal pH testing with probes placed to measure the amount of reflux, how high it's coming up, and whether it's acid reflux or other types of reflux. It can be bile reflux, it can be gas reflux, there can be other types of reflux.
So it's a probe for
Acid or reflux in general, acid and non-acid reflux as well.
pH probe.
pH probes, yeah.
And is it too much to be taking the Photonics and the Zantac?
No, that's very common actually, very common. Yeah, and actually the Zantac is actually probably a good thing because it's maybe preventing higher doses of the Protonics. It's actually quite a safe medication. So I'll go right over here and then back.
I have a question about breakfast.
The most important meal.
Dr. Manning, you did promise to talk about juicing at some point, but I feel like a lot of the choices we have today are, you hear that they're evil in some way or another. So, eggs, you're only supposed to have a
a certain amount of time a week, even though it's good protein, it's good for you. Things like those high fiber breakfast cereals, very high fiber, they're whole grain, but at the same time they're extremely processed. And then of course there's the whole juicing issue.
Okay.
So what would you
All right,
say
so
about breakfast?
All right. Yes, it is the most important meal of the day because it actually can prevent you from overeating for the rest of the day. It really manages your blood sugars and sets the stage for the full day ahead. So what are good choices? You know, there's an expression, you know, eat like a king for breakfast, a queen for lunch, and then a pauper for dinner. And that really holds true. You want to make sure that you have proteins and carbs and really balanced. I just would like for people to actually take matters into their own hands and eat at home as opposed to grabbing something on the way. You know, we have Starbucks at our convenience everywhere. They're giving us a lot of options that are not so healthy. So if we can actually just buy a whole grain cereal, have a piece of fruit, some low-fat milk, throw some nuts on there, you are gold for the day. So really think about that. Think about really taking matters into your own hands and having your breakfast at home. That's it. Don't grab your coffee and a donut or a croissant or a scone or something. Make it the best you can make it. So you can. And eggs, you know, there's a lot of new information out there about the egg. It's a lot of controversy. Does it really actually affect our cholesterol? You know, they're really saying no now. It's a lot of calories, but you can actually make it part of a healthy meal. And don't worry so much about it. It's about frying it in a lot of butter. That's really where the problem is. Okay. Oh, okay. And you wanted me to talk quickly about juicing. It is all the rage right now. I'm not saying that it's absolutely a horrible thing to do, but let's think about the actual properties of what it is that you're ingesting. So you take this machine and you throw a whole bunch of produce in there. In one side you have the juice, and on the other side you have all this pulp. Well, in places where they do juicing, that pulp is thrown out. You should actually be taking a fork and eating it. That's the stuff that you need. You need the actual whole fruit and vegetable. You should not be separating it. Okay? When you only have juices, you actually spike your blood sugars and you're hungry super fast. You need the fiber of the fruit and the vegetable to sustain you and actually help to clear your system out. This juicing is a fad. You can have juice, make it 4 ounces a day, and that's it. But I want the balance of the rest of your day to be actual whole foods that you chew instead of drinking it. Okay?
Just because of the time, I'm going to take 2 more questions. Oh, boy. We'll go, all right, maybe 3 if it's really quick. Okay, 1, 2, 3 on the back.
So I have a question about when you do an endoscopy and you see H. pylori, you traditionally treat for the H. pylori. But we believe that H. pylori is also protective for esophageal cancer. So can you comment a little bit on the rise in esophageal cancer as we sort of suppress H. pylori?
And you're not an epidemiologist, because that's a very sophisticated question. So in countries where there's a lot of H. pylori, there's not much esophageal cancer, and in countries where there's no H. pylori, there's more esophageal cancer. This is an association, but not a direct, what we call causative relationship. Meaning, if you lose H. pylori, do you get reflux disease? There's one type of H. pylori, one specific, type, which basically causes so much damage to the stomach that it doesn't produce acid. And that type is associated with a lower rate of Barrett's and esophageal cancer. But the rest of them are not. And because H. pylori is a WHO class 1 mutagen associated with gastric cancer, if you find it, we have to treat it.
And one more.
Yep.
Could you comment on use of taking normal stool and inserting it into diseased oral rectum and, kind of equalizing your biome?
Yeah.
So this is a relatively new procedure that's performed, but it's really only performed in very specific and select situations. For instance, where patients have C. difficile, Clostridium difficile, which is a type of infection. So this is not something that's recommended in any way for most people. This is a very specific case-by-case determination.
I have a question
Okay. Well, as with any supplement that you take, you never want to go and take more than what you actually need. So if there is, other factors involved like osteoporosis and so forth, that there can be the need for more, the need for less, but I'm just going to say a blanket statement in terms of GI cancers and what can prevent it. Probiotics, great topic. There's so many different products of types of probiotics out there, different strains. Our GI tract is made with thousands and thousands of different kinds, and there's different probiotics out there that actually do different things. So there's, if somebody has lots of diarrhea, I would suggest one type. If they have a lot of gas and bloating, I would suggest another type. And there's IBS, and if somebody has ulcerative colitis, I would do a different one as well. So it depends on what's going on with the person, that I would suggest a particular type, depending on the strain. So it's a whole different way of looking at it.
Person under 40 diagnosed with acid reflux that has caused some sticking, throat closing. Prilosec has been prescribed, and what is the latest on long-term Prilosec? Is that something that someone under 40 can be on for the rest of his or her life, or is that something that should be reevaluated and terminated at some point?
Yeah, I think I would try to come off it if possible. Generally speaking, I think if you've been on it for 2-3 years, it's probably not a problem. Even 5 to 7 years, it's probably not a problem. Over the long term, there are concerns about calcium loss. And hip fractures, osteoporosis, and also small but increased risk of gastric polyps. So if you can control your symptoms by other ways, diet and lifestyle modification, weight loss, and also especially for sticking sensation, that may not always be due to acid. Look for other things that are causing it as well. So yeah, over the long haul, try to come off the medication. Okay. Well, thank you for a great session. Those were phenomenal questions, and okay.